Hello, everyone, and welcome to the Don't Risk It podcast presented by VFIS Client Risk Solutions. This program focuses on the exposures our clients frequently encounter and discusses some potential solutions to help reduce these exposures. I'm your host, Chris Rogers with VFIS Client Risk Solutions, and today we're discussing patient care documentation and emergency services. Joining me on the program today are Dave Bradley from Client Risk Solutions and Nicole Dugan and Jake Hoover from our education and training team. They're here to provide some suggestions regarding your patient care documentation program. Dave, Nicole, Jake, I want to thank you all for joining me. It's a pleasure to have you on the program.
It's a pleasure to be here.
Thanks, Chris.
Thanks.
Dave, I hear the terms trip sheet and patient care report used interchangeably. Are they the same, or is this a different process?
Chris, that's a really good starting question, and it goes really to professionalism. If you think about it, EMS does not do trip sheets. That is moving a product from one place to the other, typically by truckers, cab companies, things like that. From a professionalism standpoint, especially in EMS as part of the healthcare, one of the healthcare spokes, I think it's really important for us to say patient care report because we're truly documenting the care of that patient.
So when you say patient care report, what are we talking about? What should be included in a comprehensive patient care report documentation?
So when documenting your patient care, you want to do just that. You want to document everything that has happened, during your encounter with that patient or during that call. So you really want to paint a picture of the event, so that reader or, whenever down the road, you're able to recall the events, just as they occurred. So some of those specific things should be the patient demographics, like where did you pick the patient up? How did you find that patient? What was going on as far as their history of present illness, what they were complaining about, what their chief complaint was. And then we always need to document a narrative section, and that's going to include what treatments were done and that story, painting that picture of that story of what had happened. And then a timeline of the events also needs to be documented.
Chris, Nicole makes a really good point. And to add to that, you think about it as a book. When you read the opening chapter of a book, it gets you involved in that. Then you read the middle and there's a closing. So, a book that you open and at the end you close and you know exactly what happened.
Yeah.
So Dave, you mentioned, painting the picture and giving a good description. Does that mean that someone, such as myself, who's, I'm not in emergency services, I should be able to pick that up and you described it as a book. I should be able to read front end to be and front, middle, and the end, and I should be able to discern basically everything that happened at that call.
Absolutely. Not that we would want you to do that with protected health information, but
I'm not going to do that. I would not fracture a law, Dave.
Well, I was going to say, to add on to what was already stated here, you said about like reading it like a book. It's really important that there's good flow to that. There's a lot of acronyms out there. I think chart's one of the ones that are used mostly to keep that flow. So you start with chief complaint or present problem. But you'll be able to read it from front to back and see things methodically through as you go out reading that chart. So it does make sense, because if you put things out of order, it can cause confusion. And it also, honestly, from depending on how you would do that, you could create a problem legally when you document things out of order and disarray. Your charting methods could become in question at that point. So that flow, that book, is really well needed.
Yeah, it's really important to do that also, because it could be several years down the road before this chart, would get looked at again, for whatever for whatever the reason could be. So you really want to make sure that if it's that first time that you're going back to this call, there could be multiple calls, hundreds of calls between now and then. So you want to be able to pick it up, read over everything that has been done, and have that movie like.
Well, I think that speaks to, you all said that there should be more than one set of eyes that goes onto this. I think that speaks to that, because if it's just one set of eyes, then you're only relying on that one person to let you know if it makes sense to them. So having multiple sets of eyes to see if there's things that we can improve on in our reporting practices, much better than just having obviously the initial provider who wrote it, but having more than one person review that report. Is there such thing as too much documentation then when we go into this reporting process?
It's a really good question, actually. I would say, generally speaking, the majority of providers out there probably don't document enough, realistically. I have been on the extreme side where somebody has documented way too much. It's like reading a novel instead of a patient care report. So, but probably most of the time we don't document enough. We really need to key in on certain components, whether it's family discussions, certain quotes, the scenario around us. We don't talk sometimes enough about how we extricate people in certain situations, even from houses where it takes a long time, lots of manpower. When people read your PCRs, they're going to say, why did it take you 20 minutes? And if you don't document that, that's going to be in question. So most of the time, I think, from my experience in doing quality assurance in the past, if anything, we probably don't document enough, but every once in a while, you'll have the person that you have to tell them, like, listen, this is way outside of the scope of the call. It's nice that the walls are green in the house, but it really doesn't matter in this situation.
So how would we go about documenting a clinical care error?
Chris, another great question. And, there's a myriad of ways people do it. How it should be done is document what you did. If you made a mistake, document that medicine that you gave, even if it was the wrong medicine. You don't put oops, there's an error. I'm going to make sure people know there's an error on my patient care report. You document the mistake on an incident report, but you do not lie on your patient care report. You put exactly what you did. So for an example, there's not a cardiac monitor available. The battery's failed. You don't document no cardiac monitor. You document what you did for that patient, the care you provided. You don't list falsities on your patient care report, and you report all of that through your chain, however that's set up to make sure that somebody is aware an error occurred, whether that's an incident report or an immediate report to a supervisor.
Dave, to kind of follow up on that, you said to include everything, that you did at the scene, but what shouldn't we include in the report? Are there unapproved acronyms or are there any type of wording? What shouldn't we put in a report?
So you should not put in your opinions. Like if you have strong opinions about something, you shouldn't put that in the patient care report. It shouldn't have anything to do with what your attitude or how you are feeling personally about that call or about the patient or anything having to do with that. This is strictly about what was documenting what we did as far as patient care.
And I have to agree with Nicole on that. It is so important not to have your opinion. So you're in a house that has no food for kids, document that, but don't document your opinion of the caregivers. That's not something that should be in there. Another one, and Chris, this goes back to my experience in the field. Using acronyms that are not approved or you think are acronyms that everybody knows. Perfect example is a lot of folks use LOC. It could be level of consciousness, it could be loss of consciousness, or if you're in a nursing home or a hospital setting, potentially, it's laxative of choice. So it really, to be clear, document document the full term and try and avoid acronyms unless they are universally accepted or there's an approved list for your organization or your health system.
And I was going to say that is really important from a legal component. For those of you who have had the opportunity where you have to go to court and defend yourself or read documents or have documents read in court, it's really important because they're going to look at the peers of what they say. And if everybody's having a hard time determining what you're saying using those acronyms, it's going to now question the value of your report. And that could be a good or bad thing depending on which side of the defense or where you are in the standing of the courts itself. So.
And, to add on to that, and this is a great conversation because you think about how some people write, even if they type, it's not a bad idea if you've got somebody who just can't express themselves in writing or typing, to send them to a course that helps them speak more professionally, because spell check is important and also writing at a level that exudes professionalism is important.
So to round out the episode here, we typically like to talk about any resources that we have available. Are there any things that are on the website or responder help or anything like that could help our clients out?
Yeah, we do have a patient care documentation course class, and also on our website on Responder Help, there's information on there as well.
And that's an instructor level class, right? Someone would have to, our education department would have to go out and teach them essentially how to teach our patient,
correct.
Their PCR class.
Yeah, that's correct.
Well, it was a pleasure having you all on today. Thank you for joining me, and thanks for all the great information.
Glad to be here, Chris.
Thank
Thanks.
you.
Thanks, Chris.
And I want to thank you for listening to the program and for your interest in VFIS safety resources. I want to thank our guests Dave Bradley, Nicole Dugan, and Jake Hoover once again for their time and information. Please consider subscribing to our program to stay up to date on new content releases. Also, if you like what you've heard, please consider leaving a review below. For more information about the many resources available from VFIS, please visit VFIS.com. And to submit ideas for future discussions, please reach out by email at VFISriskcontrol@VFIS.com. Thanks, everyone, and have a great day. The views, information, or opinions expressed during this program are solely those of the individuals involved and do not necessarily represent those of Gladfelter Insurance Group, VFIS, and its employees. Additionally, all views, information, or opinions expressed are provided for informational purposes only and should not be construed as legal, medical, or other professional advice on any subject matter.